Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today I have with me Dr. Jonathan Kaufman, who is David Banks' Glass Professor at one of the premier multiple myeloma centers in the country, the Winship Cancer Institute at Emory University. And he's going to talk to us about breaking news from the American Society of Clinical Oncology meeting on a totally new class of drugs, trispecifics for multiple myeloma. So, welcome, Jonathan.
Thanks so much for having me.
So we're going to talk about two of the abstracts that were presented at the ASCO meeting. So we'll start out with the first one, which is a drug from Janssen, which is a trispecific antibody. And could you just, for our audience, educate them on what a trispecific is and
Yeah.
what this particular trispecific does?
Yeah, so bispecifics are now all old news. And remember the bispecific binds two things. In the case in the most common targets that the bispecifics bind is CD3 to activate the T cells and the antigen, what's identifying the plasma cell, BCMA. And we now have three approved drugs that are bispecific targeting CD3 and BCMA. And we have one approved drug, one approved bispecific targeting GPRC5D and CD3. And so what this drug does, the trispecific, it targets three things: the CD3 to activate the T cells, and two different targets on the myeloma cell, the BCMA and the GPRC5D.
So, for this specific drug, what was broadly the trial designed?
Well, this was a initially a phase one study trying to in patients with what we call triple class refractory, relapsed refractory myeloma, refractory to three of the main classes of drugs we use: the anti-CD38 monoclonal antibodies, the IMiDs, and proteasome inhibitors. The purpose of the study was to identify the safe dose, identifying dose-limiting toxicities, coming up with a preliminary efficacy assessment, and identifying what we call the RP2D, the recommended phase two dose. This is again a phase one study trying to identify the right dose and schedule, and then the phase two is how effective is this drug?
So, what was the population of patients accrued?
So again, relapsed refractory myeloma. If you look, I think the easiest way to look at this data, because there's a lot of data here, is to really look at the recommended phase two dose. And the recommended phase two dose, again, that's the dose that's going to be moving forward. This was a really typical patient population in the relapsed refractory space. About a little over a quarter of the patients had high-risk cytogenetics. The median prior lines of therapy you see up in this on the right side, prior LOT was 4 with a range of 2 to 11. By definition, every patient was triple class refractory. There's something called penta drug refractory. That is, they're refractory to two different proteasome inhibitors. They're refractory to two different IMiDs, mostly lenalidomide and pomalidomide. What's really interesting here is that while we're trying to this trispecific targets BCMA and GPRC5D, prior BCMA and GPRC5D exposed patients were not excluded. So a quarter of the patients had either of them. Most of them had prior BCMA who have had any, that is 22%. There was one patient who had prior GPRC5D. But importantly, 75% of the patients were BCMA and GPRC5D naive. What the prior BCMA targeted therapy was a variety of different medications, antibody drug conjugates, CAR T cell, and bispecifics. And then you see here in their refractory status, again, 100% of the patients were refractory to an IMiD, 100% of the patients were refractory to anti-CD38 monoclonal antibodies. And then almost all the patients were refractory to their last line of therapy. That is, they were progressing essentially while on their last line of therapy.
So how was the drug tolerated?
So this was really important. The ability to tolerate this is really critical. And trying to make sure that we don't see any unusual toxicities when mixing these two targets. And the big picture that I get from this is that it has the expected toxicities that one would see with BCMA targeted therapies, things like lowering hematologic toxicities, lowering of blood counts, neutropenia, thrombocytopenia, and increased risk of infections. That is what we see with BCMA targeted therapies. And then in addition, GPRC5D has very unique toxicities related to the target, what we call on target, that is, that it's hitting GPRC5D, but it's not the GPRC5D that's on the myeloma cell, it's the GPRC5D that's on other cells. Keratin producing cells have it. So we see things in our oral region, and we see things in our skin and our nails. And so what we did see expected GPRC5D toxicities. And you'll see these in the red boxes here: taste changes, nail-related rash, and which is what we expect. And it appears, again, we don't have head-to-head data, but it appears in some way that this is less toxic than the approved GPRC5D bispecific talquetamab. The other thing that we saw, and I think we'll go in more details in later slides about CRS, cytokine release syndrome. And then they did a really nice job here. J&J, when looking at teclistamab, has published a series of using tocilizumab as prophylactic. We have a series institutionally, and it's become our practice to use prophylactic tocilizumab. And the data that they show here is essentially recapitulates both the data that we saw with teclistamab, as well as our internal data, which is without prophylactic toci, you see here approximately 70% of the patients get CRS. If you use prophylactic toci, that drops it to 20%. That's very consistent with what we've seen. And then you also see that by doing that, you basically eliminate any higher grade CRS. So there was 4 patients, or 15% of the patients who didn't have prophylactic toci had grade 2 CRS, and no patients who had prophylactic toci. And then, as expected, CRS happens early. It lasts on average about 2 days. It's more common to happen in the step-up dose, but it also can happen with the first full dose. And I think we see a little bit more CRS with the first full dose because, fortunately, they only used one step-up dose. So it's not surprising that we see a little bit of CRS both in the without prophylactic toci and with prophylactic toci. Importantly, we didn't see any ICANS, no neurologic toxicity directly related to the CAR T cell. So I think this really, again, this has become our practice. It's in the NCCN guidelines to use, and now we have another prospective study to show prophylactic toci can decrease all CRS and almost eliminate grade 2 or higher CRS.
You guys certainly have done some of the pioneering work that other institutions, including our own, have now adopted prophylactic toci, especially for outpatient use of these bispecifics.
Right. And it really made outpatient use possible. Without prophylactic toci, outpatient use is almost not possible with 70 or 80% of patients getting CRS. It would be too complicated.
What about infections?
So again, as I mentioned before, one of the biggest risks associated with any BCMA targeted therapy, because BCMA is not only highly expressed on myeloma cells, it's highly expressed on normal plasma cells. And then hence it's very common to get profound hypogammaglobulinemia, and hypogammaglobulinemia is associated with risk of infections. And so you see a the majority of people patients treated get some sort of infection, um, and a third of patients had a serious infection. These are the infections that we would typically think about. The upper respiratory infections, pneumonia. Several patients had COVID, and there's hypogammaglobulinemia documented in approximately 50% of the patients. I would imagine that it's certainly really in our real world practice, it's going to be more than that. And unfortunately, two patients did die as a result of infections in the setting of really profound hypogammaglobulinemia. So, we as individuals who treat a lot of patients with bispecifics, and then hopefully in the future with trispecifics, really pound that you have to check their immunoglobulins. You have to institute early IVIG. You have to really be aggressive about managing and preventing infections.
I know you already mentioned that the GPRC5D related side effects were somewhat muted. Anything you would like to expand upon?
Yeah, I mean, I think this is a whole new world to us. We never really saw these toxicities before, and we still see them. I think that they're less. The one thing that we saw that is tangible and is tangibly less than what we see with talquetamab is the amount of weight loss. And it was less than 10% of patients had grade 1 or 2 weight loss. And so it still can happen related to the dysgeusia, but it's less than what we'd see, and the impact, sort of the downstream impact on the taste changes and so forth of weight loss are less, and that's encouraging.
How effective is the approach?
So I guess I can get to my conclusions later. We'll just, in terms of the data, if you look at the recommended phase 2 dose, that's the single 5 milligram dose step up, and then the 100 milligram every 4 weeks. Every patient responded, 100% response rate. 70% of the patients at the time achieved a CR. The responses happened early. They happened in the first month. The best response happened at approximately 6 months. So this is really an impressive response rate. Everybody responding, 70% of patients achieving a CR.
I think they looked at the people who were naive to BCMA and GPRC5D drugs. So
Yeah.
what did they do?
So, so again, you see in that recommended phase 2 dose, if you look at the naive population, they all responded, and you could see that the responses were prolonged. We don't have the median duration of response yet, but you see here that the vast majority of these individuals continue to respond on treatment.
And what about PFS?
And this is so again, this is just looking at the 75% of patients who had who were naive to BCMA and GPRC5D, and at that recommended phase 2 dose. So they're getting that optimal dose, 95% progression-free survival. This is, this is remarkable data. It's been a while since I've seen data that I was this impressed with. 100% response rate, toxicities that we know how to manage, and then a year, 95% PFS at a year.
I agree. Totally remarkable. So let's move on to the second abstract that was presented. Can you tell us how this trispecific differed?
Yeah, so this was similar in that there were three things. Again, CD3, we have to bind the T cell. BCMA, uniformly on plasma cells. And the third is CD38. Now, CD38 is well known to all of us because we've been using daratumumab and isatuximab for a while now and are very comfortable targeting CD38. The good thing about CD38 as it's a validated target. And so this is also, two drugs looking to target the plasma cell. The two targets on the plasma cell that we know are good targets in myeloma.
What about the trial design with this trispecific?
So again, this was a phase one study and a phase one dose escalation. Um, again, and this is in relapsed refractory myeloma. They've had to have three prior lines of therapy. They were allowed to have prior CAR T cell and as well as prior bispecifics. And then once they identified the dose, they then did a phase two dose expansion with three different dose levels that they call low dose, medium, and high.
And what was the patient population on this trial?
So here again, this is typical of a relapsed refractory patient population. A third of the patients had extramedullary disease. In this population, 40% of the patients had high-risk cytogenetics. So just from the start, just from those two data points alone, this looks like a bit of a more heavily pretreated population than what we saw with the other one, than the first drug that we discussed. So you don't want to do head-to-head comparisons when they're clearly different trials. And then we see additional data suggests this is a slightly more heavily pre-treated population. This is a median 6 prior lines of therapy, where the other study had a median 4 prior lines of therapy. Again, by definition, all patients were triple class exposed. Half of them were triple class refractory. 70% were penta exposed. A small fraction were refractory. And then here, just under 50% of the patients had prior bispecifics and it was a variety of targets, BCMA, FCRH5, another target that we're looking for bispecifics, as well as some patients with GPRC5D.
Oh, sorry.
And then go back to one slide.
Yeah.
I just want to mention, if you look again, this one of them is BCMA, but the other target is CD38. And notice that 70% of the patients were considered refractory to CD38. So I think that's really important.
And so what about the side effect profile?
So toxicity wise, the side effects are again what we'd expect for this. First, we see hematologic toxicity, neutropenia, thrombocytopenia are the most common ones.
What about the non-hematological side effects?
Again, we see they did not use prophylactic toci, CRS just under 60%, grade 2 around 10%. So that's in the range of what we saw. CRS happens early, approximately day 2. It lasts for 2 days. Of the 35 patients, 13 received tocilizumab. One patient developed grade 1 ICANS. Grade 1 ICANS, who knows what grade 1 ICANS is? It could have just been related to a CRS event. They did have one death that they thought was unrelated to the study treatment or participation. Again, what you'd expect with both BCMA and anti-CD38, infection risk about 75%, and again, close to a third of patients with serious infections. And really, those were the major issues that we saw. We didn't see any neuropathy, which is a rare side effect that we sometimes see with BCMA targeted therapies.
How effective was it?
So again, here we see, if you look at sort of dose levels 3 to 9, so the more effective dosing here, almost 80% response rate in these 33 patients. And we don't have there's no median duration of response. But if you look at the patients who responded, 90% of the patients' response lasted for at least 6 months. And you can see with this study, if in this swimmer's plot on the bottom here, the study only goes out to 16 months. So this is a really early cut of the data, and but it looks like there's going to be a very good duration of response with this therapy.
And what about subgroup analysis?
And so this is really interesting. However you look at these different subgroups, um, if they all these response rates in my mind look all very, very similar. No prior CAR T cell or bispecific, 84%. Patients who had prior CAR T or bispecific, 71%. Patients who had BCMA target therapy, 73%. Refractory to CD38 treatment, 72%. If they had CD8 treatment within the last 6 months, the response rate was 83%. Extramedullary disease, 82%. High-risk cytogenetics, 78%. All of these are the subgroups that we worry about, and really uniform high response rates across the patient population. And what I will note is that these response rates appear to be higher than the response rates we see with BCMA bispecifics. And so this tells me that we are likely getting benefit from the additional target on this drug.
So, what is your takeaway for the audience from these two key abstracts presented at the ASCO meeting?
If you couldn't tell, I'm excited. I think this is going to be these are going to be really important drugs in therapies in myeloma. Um, they appear to be effective. The safety profile is in this patient population is one that we know how to manage. Um, there doesn't seem to be additional toxicities by putting the two targets on the same therapeutic. And so I'm really excited about the potential of these drugs to make a major change in our management of myeloma.
Well, I think everybody has seen the progress that we have made in myeloma for well over 2 decades now.
Yeah.
Seems like the best is yet to come.
Yeah. It's been a long time since I saw data, and I was how surprised about how good the data was. And that's what we're seeing with these therapeutics.
Well, I wish to thank you for taking the time to educate the audience about these exciting developments, and I hope I can draw on you again in the future for another set of abstracts. The field is obviously progressing rapidly.
Yeah. Happy to do so. Thanks for having me.
Thank you.